So good evening, everyone. Basically, I think I was asked to present GI disorders and
Yes, I think
inborn errors,
you,
right?
you can go ahead. I think this first session is on GI disorders. Thank you.
Right. Okay. So I was thinking of, so I thought of giving at least three topics in this under this title. That is constipation, which is commonly seen in children. These are very simple topics initially. Food allergies, and then to continue with the food allergies, celiac disease. So these are the three topics that I would be covering today. So basically, constipation is quite common in OPD setup because I get a lot of constipation cases on a regular basis. So it's like generally when you talk about constipation, it is easily thought that what is there to plan, what is there to plan specific nutrition intervention in constipation. It's a common presentation or common clinical condition. And but it is really, let me tell you, once I go through my slides, we'll realize like it's very important that every nutritionist, whenever she is planning a diet or specifically advising medical nutrition therapy, it's very important that you understand the etiology, because constipation, there could be varied reasons in children. So it's very important that you understand the etiology, you understand the presentation, symptoms that are actually shown, and the severity of the symptoms, and then only go ahead with planning the diet. So constipation in children is common health problem affecting about 0.7 to approximately 30% children across the globe. Sorry, across the world. So exact etiology for developing symptoms is not clear in children, and the majority is considered to have functional constipation. And I think majority of the cases will have functional constipation, like 80 to 85% cases. Now, alteration of rectal and pelvic floor function through the brain-gut axis seems to play a crucial role in this etiology. That has been documented. The diagnosis is often symptom-based clinical process, and there is a diagnostic criteria which is called as Rome-3 diagnostic criteria. And this criteria is actually used to have a clear-cut understanding about the presentation. The common perception was earlier was that Asian generally diets they are high in fiber, and that's why functional constipation would be uncommon. Hence, many of the children who presented with constipation, they generally will be subjected to detailed investigations to rule out Hirschsprung's disease. I will mention about Hirschsprung's disease in later slides. So, but now it has been actually documented, it has been studied, and there are Indian papers also which say that functional constipation is commonest type of constipation in children in India as well, Asia as well. And India, it's commonly seen amongst the toddlers, preschool children, and in 17 to 40% cases, the constipation starts in first year of life. Now, as I mentioned about the Rome-3 criteria, the functional constipation is defined as the presence of two or more of the following criteria in absence of any organic pathology, and the duration should be at least 1 month in case if the child is less than 4 years, and the duration should be about 2 months if the child is more than 4 years of age. Generally, these are the basic symptoms that one should recognize. So 2 or less defecations per week, at least 1 episode of fecal incontinence per week, history of retentive posture or stool withholding behavior. This is very commonly seen in children who come to visit our OPDs. Now, history of painful or hard bowel movement. Toilet. And in children who are less than 4 years of age, the history of retentive posture or stool withholding, generally it will be replaced by history of excessive stool retention, as retentive posture is little difficult for the pediatric gastroenterologist to assess, or is really difficult in children. Now, it's also important to understand the related terminologies. For example, obstipation. Obstipation is a terminology which is associated when we talk about constipation. So absence of passage or passage of both feces and flatus. right? Encopresses, which is called as fecal soiling. It is in undergarment. So this is also very, very common presentation in children. And this is in the presence of functional constipation due to fecal retention, and there is overflow. If there is a fecal impact, there will be overflow. So sometimes it is mistaken as this could be loose motions. So this, see, that is why it's very important that you understand what is the etiology, exact etiology. Now, fecal continence or anatomic, this could be because of anatomic or organic cause. Now, what happens is whenever there is something which is wrong in the regular routine, the dietary habits are not good, there is any kind of stressful event, or if there is a postponing, there is a habit of postponing the defecation, or the toilet training is imposed on a child too early. So these are various factors which can actually cause the voluntary withholding. This can lead to prolonged fecal stasis, and this reabsorbs the fluids, because of which the size of the fecal mass increases, and then it becomes many a times hard. There is impaction, there is more pain, and there is painful defecation. So what happens? This is like a vicious cycle. So this goes on, and this is what we commonly see in the patients who are visiting the OPD. Now, there are various risk factors, causes and risk factors for constipation in children. Intestinal causes would include Hirschsprung's disease, anorectal malformation. Then you have some metabolic causes, endocrine causes also. Due to some drugs also, there is secondary constipation that could be seen. There are other causes like anorexia nervosa. There is cystic fibrosis. There are risk factors which would be low fiber diet, any kind of psychological stress. There would be cow milk protein allergy also, not necessarily, but yes, it could also, it's in some papers it has been documented, and there could be familial predisposition also. Now, generally, whenever there is the constipation is evaluated in this manner, so this is an algorithmic approach. So basically, the clinical evaluation with the history and exam, it's very important that you take down the history. So either you can say broadly classify it as evidence of basically, investigation is accordingly if there is any organic disease which is suspected, and then accordingly if it is positive or negative, the specific treatment is given. If it is negative, then generally it is considered to be functional constipation. So this is how generally it is evaluated, and there is toilet training which should be enforced, and evaluation of rectal fecal mass is there generally, evacuation of rectal fecal mass, and this is done through basically polyethylene glycol. So there are these powders which are available, and these powders are recommended by the gastroenterologist. So if it doesn't work, then it is enema or suppository is given, and then there is a response to this. Then there is a maintenance therapy, which is either osmotic laxatives are given or stimulant laxatives are given. So this is how generally it is treated. But whenever you would like to taper down on the drugs, it is very important that the diet plays a very, very crucial role. And this is how our role comes into play. And we need to really plan the diet well. And I'll mention those important points in the further slides. So can you see here in the radiographic techniques, there's something called as fecal impact. So this is how it is impacted on the sites. And then many a times only the watery fluid comes out when they try to pass stool. So sometimes it is considered as recurrent. If this happens, this is considered as loose motion. And there is something called as biofeed technique. I will not go into details of that. But I had mentioned about Hirschsprung. So Hirschsprung's basically, it's a clinical condition, and it's commonly seen in neonates. It's a cause of colonic obstruction. And in 15 to 20% of all the intestinal obstruction cases, this is seen that they have Hirschsprung's. Then basically what happens, what is the condition? It's basically the denervation. So it is characterized by a ganglionic region, and this is in the distal colon and in the rectum. And this is basically thought to occur because there is a failure of neuroblasts in neural crest cells to migrate into the bowel segments. So what happens because of this? The normal bowel movements, that is push back push forward motion of the fecal mass, or any kind of what I would say is basically the food or formation, or whenever we talk about the stool formation and the mass which is present or it is formed, this mass will not be pushed forward properly, and because of which there would be constipation and there would be fecal impact. Now, generally, as I said, 80% cases you would see it's a functional constipation, and it is common cause in children who are more than 4 years of age. And if it is in more than 4 years of age, generally it will be there is some problem with the complementary feeding, the food choices are wrong, toilet training period is missed, or it's not been enforced. So these are various reasons, and the presentation could be chronic abdominal pain. There could be anuresis, there could be mildly distended abdomen because the flatus is there, hard stool. So these are various symptoms that would be seen. There is cross legs, generally which pushes back the fecal mass. If there is pain, the child is not able to defecate, then the child will try to cross the legs, and because of which the fecal mass is pushed back again. So this leads to impaction. So this is how basically, and because of this, it can be soiling in the underclothes, which can be seen. So once this continues the cycle, so chronic constipation occurs due to fecal retention, rectal distension, decreased sensory perception. So the entire process is it just continues, and because of which there would be a chronic condition which is presented. The treatment will be depending on the cause. If there is anal stenosis, there would be anoplasty. Acute fissures, there will be anesthetic agents, stool softeners are given. Surgical removal in case of ganglionic colon, that is called as pull-through procedure in Hirschsprung's. If there is constipation due to hyperthyroidism, it is treated by hormone with drugs. If it is drug-induced, the drug withdrawal will be there. Now, with proper training, toilet training, it is very important that you have to avoid the precipitating factor. So this is the cause, and now we have to avoid the precipitating factor. So that is if there is hardly any fiber in the diet, which is very common because children drink. I have seen children drinking about 2 liters of milk also per day. And this is something wherein our role comes into play, and we have to really educate parents regarding this. They think if you give milk, everything is given to the child, and the child is getting all the nutrition through milk. There is no need to add any other foods in the diet. This is commonly seen. I mean, it is very surprising, but many parents definitely have this kind of a misconception. So basically what we do is approximately, this is a thumb rule for calculations, age plus 5 to 8 gram of fiber per day, and increase the water intake. We generally do the fluid calculations by using Holiday-Seger formula, and additional allowance for constipation. Milk products generally will be stopped, and this is for a temporary period. Non-veg foods, if they're consuming, it has to be combined with vegetables. Many times what happens is the protein intake is very high against low fiber, and even the water intake is not enough. So this needs to be corrected. And most of the times I would advise that hand pounded grains, including the rice, the Sona Masuri variety is something which is quite high fiber. So this is recommended. And fiber foods generally at night, even the fiber allowance distribution in the meals, it has to be very, that is very important. And every meal should have that fiber. So the recipes has to be planned in such a manner that the child, whenever the child is consuming that particular meal, it will have enough fiber. So the distribution is equally important. If you're going to keep the child off milk for a very long time, it's very important that the calcium supplementation should be taken into consideration. So this is how generally we manage. Now there are commercial preparations also, like fiber supplements are there are prokinetic agents which are used, biofeed techniques which I mentioned earlier. There are enemas. So these are the this is the treatment which is given for functional constipation. And what we have to do is we have to remove all the precipitating factors from the diet. So this is how generally these cases are managed. Now, why is it so important, constipation in children? First of all, when we talk about constipation, it will be primary. So there's a primary cause for it. It can be secondary to some conditions. There could be some neurological impairment. Then also you would see constipation is there. or even it accompanies some conditions. For example, it can be acutely presented. Recently, I had seen a case of dengue fever. Unfortunately, dengue was not diagnosed till the end. Just 4-year-old child, girl child, presented with dengue, and she went into neurological impairment. Now she is absolutely into vegetative state. So whenever the child was fed, she was fed through NG feeds. She was admitted, and that time it was very difficult to take care of the constipation. So of course the fiber was prescribed, but through RT feeds, it's very important when you plan. It is taken. You need to ensure that the tube is not clogged. So in that case, you have to really think, how do you go about planning adding fiber in the diet? It can be an important symptom presentation also. For example, in case of celiac disease, you will see some children they presented as diarrhea, severe diarrhea, whereas some children they present as severe constipation also. So now you can see the difference. The cause is different, or the etiology here for presentation of constipation is different. In case of some inborn errors like propionic acidemia, also we see constipation. So this is one of the common symptoms which is presented in patients who are suffering from propionic acidemia. So you can think like whether it is secondary or it is primary, and then accordingly you have to plan specific intervention. Now moving on to the next topic, that is the food allergies. And why did I choose this topic? Because first of all, it is one of the important GI disorders, and cow milk protein allergy is very common in children. So nowadays it has reduced, the number has reduced, but earlier I used to get at least one patient of cow milk protein allergy per week. So you can see the number, how big it is. Now, basically, when we talk about food allergy, these food allergies, these are the reactions which your body actually feels or it experiences. And if it is frequently overlooked, it can cause a chronic health issue. Now, some may occur immediately after consuming the food, and which we call it as hypersensitivity or presentation, immediate presentation, food allergy. But in other cases, the symptoms may be delayed or by several hours or even by several days. And it can be referred to as food sensitivity or food intolerance. Now, food allergy generally it denotes a state of failure of oral tolerance to one or more foods that is associated with the emergence of a pathogenic T helper type 2, that is Th2 allergic immune response, and this is directed against the food antigen. Now, it also encompasses a number of heterogeneous disorders segregated by anatomy and mechanisms which are involved in disease pathogenesis. So again, I would like to say it's very important that you understand what presentation it is and then go and plan intervention accordingly. Now, generally, when we talk about food allergies, intolerances, the importance of elimination diet comes into play, right? So specific foods which will be eliminated because you suspect that these foods probably could cause allergy or they are potent food allergens, and then you eliminate these foods from the diet, and then initial period for eliminating foods that can be a measured period like for 1 month, or it is defined period 1 month, 2 months, 3 months, okay, depending on the severity of the symptoms, and then you reintroduce those foods unless there is a chronic condition. Okay, like for example, if it is gluten sensitivity or celiac disease, then it is a lifelong condition. Now, once you put the patient on elimination diet, the symptoms improve, they disappear, and there is a process of healing, what we call it, starts. So basically, what happens is, whenever you put any patient on elimination diet, how does it help? Basically, it identifies the triggers. So when you have put him on an elimination diet, we get to know exactly after we stop this therapy that which foods probably, and initially which foods could cause this kind of a presentation. So both ways it is helping. It can reduce inflammation, it repairs the intestinal permeability, and it can be a very much personalized diet approach. So it will come in the next slide, so you'll get to know how. Then phytonutrients, it can actually make it available to heal the gut when you reduce those elements from the diet, that is those potent allergens. It can reduce the toxic burden, and if you give possible options or good variety after elimination also, I mean, those specific foods. So you need to know more choices also. You need to give more choices that can even take care of the nutrition. Now, these are the commonly listed foods which may contain potent allergens. For example, I'm sure you must be acquainted with these foods: corn, dairy products, eggs, gluten, shellfish, soy proteins, or some legumes, sometimes even meat like beef, pork, and mostly the processed meat would be mostly it has more allergenic, it can give allergenic response, which is more severe. Now, in other processed foods also, food preservatives or artificial colors or flavors also can have this kind of, they can trigger this kind of a response. In some patients, coffee, tea, chocolates also can give. Nuts, definitely it's a well-known and it is documented fact that they can have this kind of immune response triggered. Some spices and condiments also, and some vegetables, fruits. In fact, some fats also are responsible. But again, I would like to tell, this is a general approach. That means this is just the basic understanding. You have to modify the diet based on the severity of the symptom and the patient, how the patient's history is. So this is something which is very important. Now, this is a simple approach which is called as elimination diet approach. And earlier it was a classic 6 foods elimination approach, and which included, including wheat, it is considered to be 8 foods, and then extended or expanded 6 foods elimination diet approach that includes even wheat, barley, and rye. This is a very general example that I'm giving here. So basically wheat, why rye and barley, everybody must be aware that in celiac disease, we even ask the patients to avoid barley and rye. And these wheat, basically, they can have this kind of a cross contact or cross reactivity, cross connection, because of which these barley and rye may give a similar kind of a response as that of wheat. So this is the basic foods to eliminate approach. Now, apart from this, there are other triggering factors in foods. So these are certain compounds which are present in certain foods, vegetables, fruits that may cause reactions in sensitive individuals. So these compounds are histamines, oxalates, and salicylates. So histamines, everyone is aware, it's a key mediator in inflammation. It occurs naturally in many foods and is also produced by the body during times of stress and allergy. Now, histamine is made and stored in the mast cells. I'm sure you must be aware that this is basic, the immune response system. Mast cells, they have very, very important role to play, and is released during allergenic exposure. And this causes dilatation of the blood vessels. It can increase mucus production and even can cause bronchoconstriction. The release of histamine results in various symptoms such as itching, sneezing, asthma, headache, etc. So it also has, many foods also have histamines, like bananas, for example. There are some fruits, some vegetables, some beverages, vinegars, and the food preservatives. Okay, so additives and preservatives such as tartrazine and other food colors or even benzoates. So they are widely used in the food industry as preservatives, and they will have a high content of histamines, right? So that's why generally it is considered that fresh foods are recommended. So even the histamine content will change when the foods are kept for a very long time, or in case of the food is too ripened, also the histamine content would increase. So this is what is the understanding about the histamine. So similarly, you have oxalates. We know the foods which are high in oxalates, most of the seeds, leafy vegetables, some fruits, and these foods also you need to consider when you plan the diet for a patient. Some of the foods which have salicylates, basically they occur naturally in many plants, and the role is they actually prevent these plants from rotting and protecting them against the harmful insects and other microbes, right? But these basically, they are also responsible for giving a immunogenic response. So similarly, as I mentioned, over-ripened fruits, some of the condiments, spices will have, or raw foods will have salicylates. So that's why unpeeled fruits and vegetables will be recommended. Why? Because the salicylates are just concentrated under the skin, immediately below the skin. So see, these things I think one should know and accordingly prescribe the diet. Turmeric also has salicylates. The only thing is that it has anti-inflammatory effect also, so we definitely advise. Only thing is that nowadays I keep on telling patients that don't buy a packed stuff wherein chemicals will be definitely added in the turmeric. So generally they prefer either organic or they make it for children, especially they try to make it at home, or somebody who is a local person is generally from where they try to get these ingredients. Now, when we talk about food elimination, we have to also talk about the substitute. So this is again a general table which explains about what all foods you need to substitute, what all foods you should be excluding, and then how can you advise something else in substitution for the same sort of a food ingredient. So if, as I mentioned about the salicylates, so generally whole fruits, or if you prefer to de-skin, then those would be advised. Some of the fruits like citrus fruits probably may give some allergenic response, so those foods should be avoided. Dairy obviously avoided, and coconut milk generally I recommend. Rice milk also sometimes. In case of young children, generally we put them on elemental formula or extensively hydrolyzed formulation or hydrolyzed protein formula. But then this is how we have to go. It's not very, it depends on how the presentation severe is. So it's based on that what you should be actually planning for a child and the age at which the presentation is there. So that also makes a difference. Now, this is a controversy that peas, some children are, or some people are, adults also, they are allergenic to pea. But nowadays, pea protein is something which is very much in talk, or it is very much in discussion. And it is said that most of the allergenic response are due to soya products or something similar. And those who are vegetarians, they should go in for a pea, and it has hypoallergenic effect. That is what they are claiming. It's a basically, it remains still a question. But then moving further, the nuts and oil seeds also, they have kind of potent allergens, and then you need to avoid most of them. Coconut generally would be preferred. So this is how we go about eliminating the foodstuffs from the diet and then substituting it with different food items. In case of sweeteners, generally jaggery is allowed. Refined sugars I generally don't prefer to prescribe. And as it is, generally we don't give within 1 year sugar, we don't prescribe, or even salt for that matter, unless there is a clinical condition which demands for that. And honey, definitely not. We don't allow, as per the IAP guidelines also, honey is not allowed for less than 1 year children. And this is because the dormant endospores of bacterium Clostridium botulinum. So this can be a toxic organism. This can produce toxic effect because of the toxin which is produced by this microbe. So this is how we have to go on planning diets in these children. Most of the spices I would advise basic mild spices, and then little severe or higher with higher I would say aroma, and all these spices or little more severe spices will not be allowed in the diet. So this is how we go about planning diets in food allergy patients. And it is very important that you educate parents regarding hidden allergens. Very, very important, because food labeling is something very I would say it plays a very crucial role, because we still don't have very precise food labels in India. So for example, if somebody is having corn allergy and cornstarch powder is present in the baking powder, so any processed food, so if the presentation is severe, even the small amount can give a problem to this patient. So this is just an example that I'm giving. Corn syrup is used in processed foods, beverages. Vinegar is used in ketchups. So these foods, any kind of processed foods, I first thing that I mentioned that you have to stop everything, because many times the presentation is very, very severe. Severe loose motions are there, vomiting is there. So you need to stop all this. And then a specific intervention, like you sometimes put them on some, as I mentioned extensively, hydrolyzed formula or elemental formula. Okay, so Carmel protein allergy is defined as an autoimmune mediated and clinically abnormal response to proteins in cow milk that occurs consistently with ingestion. So this reaction basically happens, it's a hypersensitivity reaction to cow milk protein allergy, cow milk protein, and this involves the immune system that can be called as cow milk protein. Basically, the involvement of immune system differentiates CMPA from non-allergic cow milk, what we call it as lactose intolerance. But lactose intolerance would be in case of children, it won't be generally primary unless there is a condition, disaccharide intolerance, congenital problems. But because mother's milk itself contains lactose, okay, so lactase enzyme is very well developed, and generally you will not see this kind of lactose intolerance. Yes, it can be secondary to severe or chronic diarrhea conditions when there is gut atrophy that will be seen, because at the tip of the villi there will be lactase enzyme, and if there is gut atrophy due to recurrent diarrhea, yes, there will be secondary lactose intolerance or secondary disaccharide intolerance. So basically, cow milk protein allergy, if you see, the global incidence is in formula fed babies is around 5 to 7%, and in breastfed babies it is 0.5 to 1. It is one of the most common food allergies in the early life. Now, these are the symptoms, and you can see symptoms, varied symptoms there or presentations, and this depends on basically the type. Can be either IgE mediated, non-IgE mediated, it can be mixed type, or it can be other unspecified type. So depending on the organ which is affected, you will have the presentation. In case of respiratory, cutaneous, gastrointestinal, so you have a different presentation. So you may see cow milk protein allergy presented as wheezing or coughing, or there could be laryngeal edema. It can be a cutaneous or skin presentation like atopic dermatitis. It can be a gastrointestinal presentation like oral allergy symptoms. There could be nausea, vomiting. So in this manner, you have varied presentations, and then based on that, you have to plan the intervention. Now, the initial exposure to cow milk protein can actually, the studies have shown that it may occur before birth when small amounts of food proteins consumed by the pregnant women can also reach the fetus via placenta. So it has been speculated that IgE may be already produced by the fetus in early pregnancy and can be detected in cord blood. The other possibility of exposure is early birth through intake of cow milk. So actual milk or formula milk. This is through oral intake. That means if the patient is put on a bovine formula, then yes, there could be a presentation of cow milk protein allergy. So this is how, and generally that is why even if there is a presentation which is seen in a breastfed infant, we have to take care that even the mother is put on an elemental diet. So even she is off milk products for a long time, maybe for 2 months or 3 months, depending on how the child is coping up with the intervention. So the diagnosis basically includes various tests. So there would be tests like, I would quickly go through this because I have to have a further presentation regarding celiac disease also. Okay, fine. So there would be skin prick test, there would be atopy patch test, there would be oral challenge food test. But yeah, this is what this slide, yeah, next slide. Please go to the next slide. Next slide. Right, right. Next slide. Right. So skin prick test, there would be atopy patch test, there would be oral food challenge. Generally, oral food challenge, unless it is really needed, it's not recommended. So we anticipate and then we plan the intervention. Now, measurement of cow milk specific allergen specific IgE antibodies is the very, I would say, highly sensitive test, and this is what generally is recommended, and it is performed. And there would be molecular diagnosis tests also. This I will not go into much details because this has some rationale behind it is that they represent the basis for the development of therapeutic and prophylactic vaccines for cow milk allergy. So that is why this molecular diagnosis technique has come into play. There is something called as basophil activation also. This is the rationale is basically that basophil activation has been observed in patients who present with severe symptoms of cow milk protein allergy. Now, based on this, basically a very simplified test, which are generally in the hospital setting, they are advised. So if there is a history of chronic diarrhea, rectal bleeding, anemia, when the child is on cow milk or any bovine milk formulation, then definitely the further tests are done, and it will have generally the endoscopic duodenal biopsy, which shows shortening of the villi with excessive eosinophilic infiltrates, which will be seen. There could be also rectal biopsy showing focal eosinophilia. Okay, so this is something which whenever the reports are received, this is something which is read. Okay, so this is the basic understanding. So there could be eosinophilic protocol. This base exactly indicates the inflammatory or immunogenic response basically to that. So inflammation. So there will be eosinophilic proctitis. So and when such reports you see or you get to see these patients, there will be a response to elimination diet. We immediately generally will stop withdrawal. There will be withdrawal of milk products and from the diet. And even if as I mentioned, even if the patient is on breast milk, the mother will be put on elimination diet. So, but this is considered only if all the possible etiologies for chronic diarrhea have been ruled out. So then it is considered that it is cow milk protein allergy. So whenever the diagnosis of cow milk is considered to be definitive, when the test for milk challenge is positive, milk challenge is generally after 3 months of the cow milk free diet, which is implemented in this patient. Once the patient is diagnosed to have the condition and the patient is on elimination diet, minimum 6 months to 1 year, we generally put the patients on elimination diet. Again, depending on the severity and how the child is coping up, growth factors also we consider. The biopsy findings are documented, very important because they are a supportive document. Then the cow milk is reintroduced, that is 0.3 gram per kg milk protein, that is approximately equivalent to 10 ml per kg of cow milk. And this is watched for 1 hour. If there is no adverse event, then 20 ml will be introduced, and again it is observed for 1 hour. If there are no symptoms like diarrhea, vomiting, etc., then the normal milk is introduced in feeding. But the histopathology is very important, which needs to be repeated, because even that is a solid evidence that it is because of cow milk protein allergy. So 48 hours of after 48 hours of cow milk feeding, this histopathology is also repeated. When the patient is off milk, generally as I mentioned, amino acid based formulations or extensively hydrolyzed formulations are used. Earlier, we never used to get these amino acid based formulations or extensively hydrolyzed formulation very easily. So we have, in fact, I've used intact proteins also, but they are lactose and sucrose free. Hypoallergenic comminuted chicken based formulations also I have used in these patients. And parent education is very important, that you need to provide a list of allergens to be avoided. Right. When the challenge is considered positive, there is a reappearance of histological changes after the cow milk re-exposure with or without symptoms. If the child is on breastfeeding, as I mentioned, she will be off milk products. Follow-up visits, very important, focus on clinical response to cow milk withdrawal. This is assessed in the form of checking a stool diary, anthropometric measurements, generally the general clinical assessments like if there is an improvement of appetite, reduction of the symptoms, irritability, and long-term growth and development assessment is equally important. So you need to follow them for a longer period. Now, reintroduction generally is considered post 1 year, post 2 years, or sometimes even at 3 years also. Now, in this case, calcium supplementation is definitely considered because we are putting them off milk. Now, this is how we generally treat these patients. So, and this is the medical management, I would say, acute management and long-term management. So the acute management, basically the patients with previous anaphylactic reactions or severe asthma, they have a higher risk than the other patients and treated with non-steroidal anti-inflammatory drugs. There is emergency management of anaphylactic reaction as per the guidelines which are recommended, and antihistamines in treatment of more severe symptoms. It's very important that long-term management equally, that is, if you're going to keep this patient off milk for 1 year or 2 years, the algorithmic approach should be followed later also. So long-term management is equally important. Parent education, variety of choices, because children, you need to ensure the monitoring growth parameters is equally important, and every time on follow-up, evaluating the nutrition therapy. So this is what is about food allergy. So now just to continue from food allergy to celiac disease. Now, important aspects of celiac disease, it's very important, as I mentioned earlier also, the disease understanding, the pathophysiology is knowing about that is important. Presentation is equally important, like whether it is a severe diarrhea, as I said, or it can be anemia, it can be sometimes even constipation, severe constipation. So this is varied presentation also should be considered when you plan the diet for these patients. So basic mainstay, or the mainstay of the treatment, or the basic treatment is gluten-free diet. But it is not just, there are n number of, I would say, dimensions that need to be added when you plan diets for these patients. So the nutritional concerns is malabsorption in these patients. The detailed information about the parents, patient is taken, parents, family, culture, everything is important. Assessments as usual, anthropometric, nutritional data, and if it is approach is from the to the hospitalized more severe cases, then it will be different. So that I will talk about in later slides. OPD, it is comparatively, these patients are stable. They can be presented as constipation, as I said, or severe anemia at times. And very important that they understand about gluten, gluten-free foods, gluten-free kitchen, gluten-free shopping. So all these parameters, or you can say aspects, should be considered when you educate the parents. And it is difficult to actually follow this kind of strict diets. Yes, definitely there would be hitches and hurdles. And it's very important that you increase awareness. Maybe you can conduct workshops for these patients and parents. So the pathophysiology basically is, there's a genetic predisposition, there's immune system, immune response through the first environmental triggers will together have a presentation of celiac disease. So it's a multifactorial autoimmune disorder that occurs in genetically susceptible individuals. Very important that these understanding why I said that, because once you know that where is gluten present, so there will be a number of foods wherein gluten is naturally present, whereas foods which may have something called as vital gluten, which is present in most of the food industry preparations or manufacturing products. Okay, so this is how one needs to understand. Now, basically, when we talk about gluten-free diet, gluten, they are toxic for patients with celiac disease, and we have to even mention about wheat, rye, and barley because of the cross-contamination. So villus atrophy is very common as GI. So these are various symptoms which you would be seen. There would be gastrointestinal symptoms, so there will be non-GI symptoms also. And in case of gastrointestinal manifestation, there will be villus atrophy. There would be persistent diarrhea, malabsorption, faltering of growth. There could be idiopathic short stature, abdominal pain, vomiting. So these are all GI symptoms. Apart from this, you may see some symptoms like skin presentations like dermatitis, herpetiformis. This is also common, and this is a peculiar sort of a symptom which is seen in these patients. There will be dental enamel effects, there could be osteoporosis, delayed puberty, there could be recurrent mouth ulcers, there could be unexplained anemia, and sometimes even unexplained liver disease. So these are varied presentations. It's very important that there is a particular algorithmic approach which is followed. So in symptomatic children and asymptomatic children, so the initial screening, generally when we talk about celiac disease, we talk about tissue transglutaminase antibodies. So this is what is the first screening that would be done. And I would say the gold standard, so one second. Right. One second. Sorry. Right. So tissue transglutaminase and basically genetic testing, and the gold standard test will be duodenal biopsy, wherein you would see that there is villi atrophy, and the biopsy will show that it is graded as Marsh grade classification 3. So based on this, it is a confirmatory diagnosis for celiac disease. And you anticipate micronutrient deficiencies because it's a malabsorption syndrome. And basically, depending on the presentation, you have to plan the nutrition intervention. So initially, appropriate assessments in case of chronic diarrhea, hydration to improve nutrient absorption, micronutrient should be considered, iron, calcium supplementation, elimination diet. In case of there is short-term presentation, disaccharides intolerance would be seen. So you have to put the patient on lactose and sucrose-free diet. If there is, of course, when there is a malabsorption, you also consider the MCT based preparations or peptide based preparations or formulations which are gluten free. And this is how you go about planning nutrition intervention. Next slide. Right. So, and in case of anorexia, you have to plan a different strategy. In case of constipation, you have to take care of the fiber and even the fluids. So this is how we go in case of mouth ulcers, B complex supplementation, antioxidants to subside the inflammatory presentation, inflammation which is seen. So this is how one goes in planning intervention. Sometimes you have type 1 DM presentation also, like you have celiac disease and type 1 diabetes. So generally, basically, type 1 diabetes is because of celiac disease. So this is, so when you have, this is another area that you need to plan intervention for, because type 1 diabetes, first of all, it is gluten free, and then you have to manage the type 1 diabetes presentation as well. So long-term management is very important that you give options for naturally gluten-free foods. That's because the compliance will be poor if you don't give more options. There would be some pseudo cereals which are available, so you need to include them in the diet. Gluten-free products which are commercially available. So these things need to be enforced. So these need to be emphasized when you counsel a patient. So assessment, as I mentioned, that you need to do all the regular assessment that we do as a nutritionist. And if there is a severe presentation, then it's a hospitalized approach. So there is a diarrhea, severe diarrhea. So how do we begin? We generally begin putting the patient, as I said, that you anticipate disaccharide intolerance. Of course, gluten-free is the mainstay, and we follow the standard guidelines for managing a diarrhea patient. So we, as I said, secondary disaccharide intolerance, elemental formula sometimes you have to give, because if the loose motions, they don't subside, you have to. Sometimes you can give, as I said, intact protein with lactose and sucrose-free formulation is also advised. Sometimes MCT-based preparations are required or peptide-based preparations are required. We do fluid calculations based on the Holiday-Seger formula, and we consider additional allowance or age and severity of diarrhea both. So the diarrhea, based on that, you can plan 250 ml per kg per day also, depending on how much is the output. Now, estimation of calories based on the RDA. Sometimes you have to give the patient is underweight, 120% of the RDA. Initially, you estimate, you need not implement the entire amount. You go gradually increase as per the tolerance. You have to sometimes put the patient on NG feeds. That's because orally there would be vomiting, which is one of the symptoms which is also commonly seen. Then you continue the same formula. Once the patient improves, you can still put the patient, of course, you need to put the patient in, still continue putting him on lactose and sucrose free for a while. When the child is fine and the child is about to get discharge diet will be separately given. Low sorbitol fruits will be advised if the child is a little older, like 2 years and above. So these can also aggravate diarrhea. So we generally recommend low sorbitol fruits initially. Of course, the lactose is also off. The milk products are off. So after 15 days, depending on the status, improved status, we call the patient post 15 days or 1 month to visit the OPD, and all fruits generally are introduced. Sucrose is gradually introduced. Initially, buttermilk or curd is introduced, and the milk will be introduced post 1 month or 2 months, depending on the child, how the child is coping up. So it's extremely important that you counsel parents in such a manner that the severity is understood. So home grinder is something I have just underlined here. Next slide. Next slide. Next slide. Next slide. Next slide. Right. Okay. So home grinder is a must. So this is because we don't get, it's likely that all the products that we have may not be 100% gluten free, although there are few products nowadays available in India. Initially, it used to be very, very difficult. But home grinder is a must, because otherwise they will have less food choices. Sometimes these gluten-free products are very expensive. Some of our patients really cannot afford. So a basic one-time investment of grinder is preferred. So this is something which is which you need to counsel the parents regarding. Then go gluten-free. Obviously, all these products will be out, and then you have you generally give a list of products that the child can have. You need to give them the recipes. As I mentioned about sorbitol, here you can see some of the fruits which have higher sorbitol content, and generally whenever you have 5 gram, greater than 5 gram sorbitol per 100 gram or one serve will aggravate the diarrhea. So these are this is a table which indicates the amount of sorbitol. Then I think I'll skip these slides because how it was evolved. Yeah, knowing the gluten is something which is very important. So basically gluten, it comprises roughly of 78 to 85% of the total wheat protein, and is a very large complex mainly composed of polymeric chains. Okay, and that is how they are responsible for triggering the immunogenic response. So right. So basically, gluten is classified into two main fractions according to their solubility in aqueous alcohols. The fraction soluble in aqueous alcohol is gliadin, and those which are insoluble are called as glutenin. So whenever it is the tests which are done, diagnostic tests, you can have a look at it, like which test are supposed to be and which test are picking up which of these components while presenting or diagnosing it as a celiac disease. You can see here wheat is broken down. It's a protein. It has lectins. It has protein, which is gluten, and it is broken down as gliadin and glutenin. And this is generally the other one. The gluteomorphin is supposed to be toxic, and gliadin, which has various versions or different types, alpha, beta, gamma, and these are ones which are next slide, next slide, next slide, next, 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 right, next, right, yeah, stop, right. So basically transglutaminase. So this is the standard test for antibodies. So what we talk about is tissue transglutaminase, and this will pick up these gliadin antibodies. So diagnosis is basically based on the antibodies in your blood, TTG, IgA test for most children and adults, and the normal value we consider is less than 15 units per ml. For younger children, less than 2 years, generally deamidated gliadin, IgA, IgG antibodies also are recommended. And in normal patients, otherwise older patients, even IgA anti-endomycin antibodies are also recommended. It's very important that before you put this patient on gluten-free diet, these tests needs to be performed. Otherwise, you may have wrong results, right? And the genetic testing is to rule out if it's not a celiac disease. Then genetic testing is done, wherein HLA, that is human leukocyte antigen DQ2 and DQ8, which are found generally in these patients haplotypes. So this is something which is in the genetic testing, which is confirmed. And duodenal biopsy, I would say, is a gold standard test, wherein villus atrophy and Marsh grade classification, grade 3, will be seen. So this is what I am talking about, the mucosal biopsy or the duodenal biopsy, and wherein you can see here that these are the normal villi that you would see, and whereas in the second, there's a villi atrophy. So these villi you would see, they go into a blunt form, and because of which there is malabsorption. Monitoring is very important. You need to monitor these patients every 6 months. Initially, the TTG will be repeated, and then yearly, generally, the patients come to you. Later, generally, once the patient is coped up well, the child has picked up with growth, and there are no such specific complaints, they can see you after 2 years also. So, and these tests generally will be asked them to repeat, so that you can actually check if there is any problem with adherence to the diet. Sorry. Very sorry. Oh, so sorry. No, I don't know what happened. 1 second.
We can hear you.
1 second.
Vaishali ma'am, the slide is right.
We can hear you.
Yeah.
1 second. No, I'm about to finish, ma'am.
Yeah, that's what we can hear you. I
Right.
said we can
So,
hear.
right. This is something I just wanted to mention. Basically, you give the parents a list of foods which have gluten in it, and it's not that naturally gluten is present. As I said, the foods which are processed foods also will have vital gluten present in it. It's also important to know the options that they can use which are naturally gluten free. So these are some pseudo and mono cereals which they can use: teff, fonio, and buckwheat, amaranth. So these are the varieties which they can use. Millets, our millets are also jowar. They can use ragi, quinoa. So all these can be part of their diet. The concept of kitchen-free, gluten-free kitchen is extremely important. So if one patient is in the family, generally the entire family has to go gluten-free many a time. So gluten-free kitchen concept is very important, because these utensils prone to give gluten contamination. So whatever equipments, whichever utensils that you are using in the kitchen, they have to be separate for these patients. It's likely that they have some leftover gluten if it is used for a normal person, preparing normal person. You have to explain all this to the parents. And labeling is very important. And we have something called as Codec standard for gluten-free foods, and this is Codex Alimentarius Commission. Okay, and this is updated every year, and this will actually give you actually will mention which foods will have so much of gluten. If it is 5 parts per million, if it is less than 5, if it is 10, if it is more. So this basically Codex is a useful document, and it is an endorsed document. So it is generally used, and you can pick up a few details from this document when you plan a diet for these patients. Why I mentioned about the vital gluten part. So you will be surprised to know wherein this vital gluten is used. So it is used in most of the commercial preparations, including beverages, soups, gravies, meat, sausages, cheese, ice cream. So all these foods will not be allowed, even ice creams for that matter, cheese, these we don't allow for our patients unless it is specifically mentioned, or it is from a NABL accredited lab wherein HACCP certification is there, we allow, because we don't get these products easily in India. We do have some local products which are available in India which are gluten free. Yes, we do have, but many of these products, it's very difficult. Even the spices, next slide please. Even the spices that we use on a regular basis for, next slide. Yes, next slide. Yeah, correct. No, go back. Right. Okay, even the spices that we use, we need to actually not allow in their diets. So even the spices that we get in the packet, the regular ready to use spices, so none of the ready to use foods we generally recommend. So herein when the glucose, the vital gluten is used. I think I'm almost done. So it's very important that you have some support groups, and it's important that you have some labs which can actually give you the product to be tested for gluten presence, whether it is present or absent, at least the basic, and the amount of gluten that is actually present, whether it is safe for the patient. So these are various actually companies, the labs basically, which are doing this test. So these are authorized labs, and the reports from these labs. Go ahead. Just next slide. Next slide. Next slide. Next slide. Right. Next slide. Correct. Right. So it's very important that you have support groups for this, so that it is easy for you to arrange workshops and increase awareness among them, and actually emphasize on importance of gluten-free, because sometimes the patients unknowingly can go in for something which has gluten contamination in it, and there could be problems, and then without realizing, because immediate symptom presentation may not be seen in all patients, and over a period you can see that there is no proper growth, or there are some other symptoms which start presenting after 2 months or 3 months, and there will be probably sometimes the height is not growing properly. So you may see these kind of symptoms also. So you need to ask them to get these tests, especially the TTG. If the TTG was positive earlier, and then you have to see if there is that can actually tell you or diagnose if there is strict adherence or no. Right. So a flour or a dough has been treated with basically a culture of bacteria, which will conduct a process wherein they will neutralize the gliadin particles, or there are antibodies which can be neutralized through specific drugs or specific formulations that have been made. This is still under trial. So at present, at least, following a strict gluten-free diet in celiac disease is the mainstay of treatment. Thank you very much.